results of the data, we decided to relaunch and make it an annual meeting where we can increase the awareness about sudden cardiac death and about all the therapies that are available. So today we have really great speakers. Our key speaker actually is very close. We will start by asking you a few questions, if you don't mind. Some of you have had these little keypads that you have. I would like you to look at the questions, and if you can answer them, that would be great. And most of the questions, some of them you might say that they're stupid, and some of them you're going to say, well, this is, I don't know that. So without further ado, I'm going to make the clocks for you, and you can start doing the polling once we do the clock. So our mix is, we've got no residents. So I don't know where are the PGY 2 and 3s. They're not here. That's not good. We've got a couple of fellows. We've got cardiologists, which is great. And we've got other. Let's look at the next question. Years in practice. Are you still in training? 1 to 3 years, 3 to 5 years, 5 to 10 years, or more than 10 years of practice? Okay. Again, in training, 67%. That's good because that's the people that we want to really target. We've got a couple of veterans here. That's great too. So we have the nice mix. A percent of heart failure patient seen per month. So how many patients of heart failure do you see a month? 1%, 5%, 10%, 15%, 20%, or 25%? Or I don't know. We should have music for this, right? 8 responses. We should have 36 responses. Right? All right. So the majority says, 33% said about 10%, which is about what the heart failure representation in practice, about maybe 15, 20%. Next question. Percent heart failure referred for an ICD per month. 1%, 2%, 3%, 4%, but I don't refer for ICDs. I don't like them. Okay, 1%. I like that was split here between 2%, 4%, and 5%. Not many people die of sudden cardiac death. Is that true or false? What do you think? Okay. We like that. How about this? Sudden cardiac death claims more lives each year than these diseases combined: lung cancer, breast cancer, and AIDS. What do you think about that one? True or false? Okay, so 27% thinks that this is false. You can't predict who will experience a sudden cardiac death event. Is that true or false? You guys are doing okay. Just keep voting. You have 5 more. Okay, so 33% thinks that we cannot predict who is going to die suddenly from a sudden cardiac death. How much percent reduction in chances of resuscitation success every minute? If every minute passes and you delay resuscitation, what is the percent reduction in survival? Is it 1%, 3%, 5%, 10%, or 20%? Okay, very close. 47% of the people said 10%. Most heart failure patients are not dying from sudden cardiac death. What do you think? True or false? Okay, false. So the majority of heart failure patients die from something else other than sudden cardiac death. People who have had a heart attack have a sudden cardiac death rate that is how many times that of the general population? 2 times, 6 times, 8 times, 12 times, or 15 times? Higher. So people who had a heart attack, are they at sudden cardiac death risk more than the population or not? Okay, 33% of us said that 8%. I'll tell you the numbers later. Recent trials showed that beta blocker and ACE inhibitor are the most effective therapy option to prevent sudden cardiac death. Is that true or false? Okay, again, 55% of the people think that it's false. It's good. ICD reduce mortality by what percentage on top of the optimal medical therapy? 12%, 23%, 33%, or 50%? Okay, 58% of the people said about 33%. All right, so we got a lot of questions, and I think it's about time to start answering them. So our goals tonight is to describe the current trends of an epidemiology of sudden cardiac death, describe whatever guidelines we have, updates on heart failure therapy, and find the risks of patients who are at sudden cardiac death, and look at genetic predictors of sudden cardiac death. So where is the gap and the rule of the ACAP program? Well, primary care physicians are not adhering to life-saving guidelines. I'm not saying that because primary care physicians are not on board, but some of them are not really aware of the guidelines, and some of them think that ICDs don't really work, and if they work on specific people, not the entire population. There's a study that was done for more than 300 physicians in northeastern Ohio that was surveyed and tested their knowledge of when a patient should be referred for cardiac rhythm specialist. Less than 25% of the responder knew when a patient should be referred for an ICD. And of those patients who do refer patients, 80% indicated that patients were reluctant to undergo ICD. So there is 2 gaps: knowledge as well as the stigmata about the ICD implantation. So the study demonstrated the need for increased awareness and education for patient and physician about sudden cardiac death. And like we always say, guidelines that are not followed are of no value. So guidelines must be implemented, and to do this, of course, the American Heart Association and the Get With the Guideline programs have pushed further in trying to show people the need of complying with guidelines and the result of that. Here in St. Luke's, we started the Advanced Cardiac Admission Protocol that all of you are aware about in 2004, that started with the pain pathway. And years later, we have almost 9 pathways, including the escape pathway. There is a key feature of all these pathways that are all built from expertise of attendings and senior attendings. There is collaboration between fellows, residents, nurses, as well as administration of the hospital. And all this was done in conjugation of including the patient into their own management. So before we introduce our fabulous speakers, I want to just clarify some of the myths about sudden cardiac death. The first myth is not many people die of sudden cardiac death. We ask you this question. According to most studies that we've shown, that sudden cardiac deaths claim more people than the entire lung cancer, breast cancer, and AIDS together. Significant killer in America, 95% fatal without ICD, without ICD protection, 98% survival was an ICD protection. So you've got a disease that you can actually predict who's going to have it and can save lives as well. As far as the resuscitation question, you've got chances of success is reduced 7 to 10% every minute passes without resuscitation. So unless you get to the patient very quickly, the chances of survival is very low. Myth number 2, you cannot predict who will experience a sudden cardiac death event. More than 60% of you said, yes, we can't. Well, we've got an ample trials that told us that we actually can. You've got Scott Heft, you've got Made It 2, you've got Definite. All of them had told us a patient with low ejection fraction, class 2 or 3 heart failure, sometimes with 4 heart failure, when they go into the categories, are at higher risk of sudden cardiac death, particularly patient post-MI and patient with left ventricular dysfunction. Myth number 3, most of my patients had their MI many years ago and therefore are no longer at risk of sudden cardiac death. We hear this a lot. Well, again, from the Made It 2 trial, you see up to 120 months out of the acute MI, patient who get an ICD live longer than patients who do have only conventional medical therapy. So ICDs save lives even 5 years after an MI. Myth number 4, my heart failure patients are not dying from sudden cardiac death. Arrest. Well, if you look at these pies from the Merit Heart Failure, which is a big heart failure trial, if you look at the big chunk of either class 2, class 3, or class 4, you find that patients in red are the chunk of patients who die from sudden cardiac death, and these are 64% in class 2, almost 60% in class 3, and 33% in class 4. So sudden cardiac death, kill people. Myth number 5, medication are just as effective and less expensive. Again, I will quote some of the trials that we have. Merit Heart Failure, you can tell that these are the patient total deaths and patient who had sudden cardiac death. 54% of deaths on optimal heart failure medication. So what does ICDs do on top of optimal medical therapy? From the trials that we know that it reduces mortality by 23% on top of optimal medical therapy. So if you'll be able to save 40% of the patients alive by beta blocker, adding 23% is really getting a bang for your bucks. Myth number 6, ICDs are too expensive to use with all indicated patients. Well, this is a very nice slide because it looks at number to treat. This is ICDs and all the trials to get really to save a life. And this is the numbers you need to treat to save a life in captopril trials, in toprol XL trials, simvastatin, amiodarone. Very little amount of patients you need to treat to get to save a life. Also, something that is really important to see, that most of the money that spent on pharmaceutical, very little really is spent on ICDs and compared to statins, $15 billion. You're talking about $4 billion in something that we know save lives. Myth number 4, sudden cardiac death is too big of a problem. Our hospital is not resourced to identify at-risk patients. Well, you'll hear tonight about the escape pathway to teach you how can you find these patients. The last myth, and I had to put it, I didn't put it 2 years ago, but of course after the publication that came up in January last year, I thought that I'm obliged to do. In JAMA paper looked at data extracted from the National Cardiovascular Registry, revealed that there is deviation from the evidence-based guidelines for ICD implantation within An estimated 22.5% of these procedures did not meet criteria. So the paper by Dr. Al-Khatib looked at patients who got ICDs and found out that 22% of these patients did not get evidence-based indication for ICDs. So as I told you, we had our escape pathway 2 years ago, collected data, almost 1,000 patients. So I said, well, Dr. Khatib, let me see what you did. Let's see what our hospital is doing. So I found out of the 845 patients, we only had 19% of these patients had ICDs. And if you compare the two groups, you'll find that there's really no difference between the group who had ICDs versus people who didn't have ICDs. Mind you, everybody was eligible for ICD implantation. And if you look at the outcomes, of course, patients who had ICDs had much less outcomes. Not just that, we actually repeated exactly the same curve that the Scott Heft have shown before, which ICDs save lives and decrease mortality by 34%. So what we're saying is Dr. Al-Khatib paper, intriguing, it's really interesting, but I think if you look at it very logically, you'll find out that maybe 22% out of the 19% who gets ICDs, that becomes a minuscule amount of percentage of people who should we worry about. What I'm worried about is the 80% of people who do not get an ICD. When we looked at these groups of people who did not get an ICD, women, of course, and Hispanics and African Americans had less ICDs than whites and Asians. When we looked at multivariate analysis, we also found something very interesting, that beta blockers save lives, reduce mortality by 30%, AC inhibitor by 20%, ICDs by 40%. So ICDs are still a very, very valid and important therapy for all heart failure patients. I just want to mention that the ACAP program have really a lot of senior attendants. All of them are inputting in all the pathways, and there are a huge group of researchers who are working with us. Some of them you've seen today. They are dedicated. They're working day and night, collecting data, cleaning data. So I really cannot give them enough thank you for all their help that they're doing. And without further ado, I would like to introduce Dr. Farooq Chaudhry, who is our Director of Echocardiography, and he is the Assistant Professor of Medicine in Columbia University, as well as the Assistant Chief of Cardiology. Dr. Farooq?